endocrine physiology, growth hormone, antidiuretic hormone, as well as prolactin. All right, starting off with growth hormone. Growth hormone is relatively easy and straightforward. So once growth hormone is released from the anterior pituitary, it's going to go and activate the liver to release IGF-1. This molecule IGF-1 is going to help growth hormone do its actions. So everything that growth hormone does is through IGF-1 activation. That's why we care about growth hormone, okay? It really is, it's just sitting back and relaxing while IGF-1 does all the work. Okay, the question is, what does it do? Well, it's in the name. It allows for growth of the bones and growth of the muscles. And so the question is, how does it do that? Well, IGF-1, once released from the liver, due to the fact that GH is activating it, IGF-1 is going to increase insulin resistance. Increase in insulin resistance leads to an overall increase in blood glucose levels. More glucose in the blood means that we have more glucose available for growth. Okay? That's all that it is. So more glucose in the blood leads for more muscle growth and longer bone growth. Okay? So that's all that's occurring, and it's due to increased insulin resistance secondary to IGF-1. Okay. Now the question is, how is it released? Well, it's released in a pulsatile manner, just like GnRH. Okay? So it's released in a pulsatile manner, GH and IGF. And so a question that will be coming up later on is associated with this pulsatility and what we should check for. And if they ever ask you about the pulsatility, which one you should check IGF pulsatility. Okay, but we'll talk about that later on. Now, the question is, excess secretion of GH can lead to two pathologies. Once again, we'll cover the pathologies associated with excess GH later on, but I want to just touch on it real quickly. The excess GH in children is going to be gigantism. If you have excess GH release in adults, it's going to lead to acromegaly. And acromegaly is just like going to be long fingers, long toes, harsh facial features. You'll see that presentation later on, but once again, we'll cover it later. Now, the question is, how can we stop this? Well, we can stop this by treating it with something that decreases GH. Well, what decreases GH in our body? Somatostatin, somatostasis. Okay, so if we give a patient a somatostatin analog, something that we've already made in the lab, okay, then we can have an overall protection against some of these pathologies, hopefully. Okay, and so the drug name for a somatostatin analog is octreotide. Octreotide is the one drug that you have to memorize. It's a somatostatin analog that can be helpful in these patients that have excess growth hormone. The last question is, why do we have so much growth hormone? Well, it could be due to a pituitary adenoma. Now, we already discussed the most common pituitary adenoma is a prolactinoma. We have excess prolactin. It leads to a whole mess in our hypothalamic pituitary gonadal axis because increase in prolactin obviously leads to a decrease in our GnRH release. And so we have amenorrhea, and we can also have galactorrhea seen due to the excess levels of prolactin. But a pituitary adenoma doesn't have to always involve a prolactinoma. It can secrete growth hormone rather than prolactin. Now, it's relatively lower yield, but it still occurs. And when it occurs, it will present with those two things, acromegaly, if it's in an adult, or gigantism, if it occurs in a child. All right, so that's all you have to know about growth hormone. Up next is antidiuretic hormone. We already discussed it. It's also known as vasopressin, okay? And it has two functions. The first function is to regulate blood pressure, and it regulates blood pressure via its V1 receptor, okay? Now, the question is, why do we have two names? ADH, antidiuretic hormone, as well as vasopressin. If they're the same thing, why would we have two names? Well, let's think about it. So this hormone, this molecule, acts on the V1 receptors to regulate blood pressure. Well, how does it regulate blood pressure? It increases blood pressure. Okay? And how does it do that? It allows for constriction of the smooth muscle of our arteries to increase our blood pressure via the V1 receptor. Hence the name vaso, which is vessels, pressing. So you're pressing the vessels, which leads to an overall increase in blood pressure via the V1 receptors. Perfect. So that's where vasopressin comes from. Now, how about the antidiuretic hormone name? Where does that one come from? Well, it comes from its actions at the V2 receptor. At the V2 receptor, we have another issue going on. The antidiuretic hormone is going to lead to an overall increase in water reabsorption, okay? And this is its primary function. The primary function is to regulate the serum osmolality in order to bring in more water. So it will sense if there's dehydration. It will release ADH from the posterior pituitary. It will go act on the collecting duct in the kidneys and allow for an increase in aquaporins, allowing for an increase in water reabsorption. Okay? So those are the two most important things that you have to know about antidiuretic hormone. The V1 receptor is going to help regulate blood pressure by constricting the blood pressure, hence the name vasopressin. And then the primary function is going to be acting at the V2 receptor, and it's going to sense serum osmolality. If we have high levels of serum osmolality, it's going to sense that we're dehydrated, and it's going to allow for an increased reabsorption of water. Hence the name anti-diuretic, because we're taking water out of the urine. We're not diuresing it. It's anti-diuretic. Okay, very important. Now, the pathology associated with this is that we have ADH levels, okay, is going to be decreased in central diabetes insipidus, okay, and they're going to be normal or increased in nephrogenic diabetes insipidus. We'll talk about those later on, but essentially, central diabetes insipidus means that there's a problem with the pituitary gland, so we're not even releasing any ADH, so you're just peeing out water. And then nephrogenic diabetes insipidus means that there's a problem with actually the V2 receptor at the renal kidneys. So ADH is fine, the levels are fine there, but we can't actually bring in the water because our ADH can't bind those receptors. Okay, and that's nephrogenic diabetes insipidus. So a problem with the nephron, right, is going to be nephrogenic diabetes insipidus. A problem with the brain, the posterior pituitary, is going to be central diabetes insipidus. All right? Now, desmopressin is an ADH analog or a vasopressin analog. It's known as desmopressin. It's very helpful. They named it relatively similar to vasopressin, that we use for a lot of pathologies, okay? And it's very helpful. All it is just an ADH analog, so it acts the same as ADH, and it's a treatment for central diabetes insipidus, okay? So we can use it in patients that can't produce their own ADH. We could just give them ADH analog known as desmopressin. Makes sense. Can we give it to patients with nephrogenic diabetes insipidus? No, because we have normal levels of ADH. The problem isn't producing ADH. The problem is ADH not being able to activate those V2 receptors or act on those V2 receptors. So giving desmopressin to a patient that has nephrogenic diabetes insipidus isn't going to do anything because you already have normal levels or maybe even increased levels of ADH flowing through your body. And that's a key differentiator. But once again, we'll cover that later on in the pathology of endocrine. All right? So overall, that's what you need to know about ADH. Lastly, we're going to cover prolactin. And the reason I like to kind of put prolactin with all of these as well is because we talked about growth hormone, and prolactin is going to be released somewhat similarly, and it has its similar effects. Okay, so for prolactin, it's released by the anterior pituitary, and once again, there could be a prolactinoma. Okay, and that's just an anterior pituitary hormone releasing tumor. Okay, so known as a pituitary adenoma. Just like growth hormone, it can also release prolactin, but prolactin is more common than a growth hormone pituitary adenoma. Okay, now what's the normal functions of prolactin? It's going to stimulate milk production, right? We already talked about it. It inhibits ovulation in females and spermatogenesis in males. And how does it do that? Once again, it inhibits the GnRH synthesis. Okay, so once again, excess amounts of that prolactin, what are we going to see? We're going to see amenorrhea in women, impotence in men, okay? And then you could also have like a headache and bitemporal hemianopia, vision loss, if you have a prolactinoma, all right? It's structurally the same as growth hormone, and so that's why they kind of put them both together, but completely different functions. Lastly, how do we regulate it? Well, we said prolactin is regulated by dopamine. How does dopamine know when to be released? Well, actually, prolactin senses itself, okay? So prolactin, in turn, actually inhibits its own secretion by increasing dopamine synthesis. So prolactin will go increase dopamine synthesis because it knows to kind of slow down when it knows when it needs to be slowed down itself. Lastly, TRH, once again, we discussed this, but important aspect, TRH increases prolactin secretion, okay? And dopamine has a strong effect on prolactin regulation, and so does TRH, but dopamine's a little better, okay? So keep that all in mind. Lastly, I'm just gonna cover the drugs to kind of help regulate prolactin. We can have dopamine agonists, okay? Which we did not discuss before. We already discussed dopamine antagonists with the antipsychotics, but dopamine agonists, what do you think that would do? Dopamine agonist is going to increase dopamine, leading to an overall decrease in prolactin. And so that's going to help us use to treat prolactinomas, okay? And those two drugs are bromocriptine and cabergoline. Okay, so those are two drugs that are dopamine agonists that help us inhibit prolactin secretion. Makes sense in patients that have prolactinoma. And once again, I'm going to cover it again. The dopamine antagonists, like antipsychotics or metoclopramide, which we'll discuss way later on in GI, as well as estrogens, these stimulate prolactin secretion, okay? And keep that in the back of your mind. So overall, that's going to cover our GH, growth hormone, antidiuretic hormone, and prolactin section.